in just a moment. Just want to make a couple of announcements before we get started. One is I want everybody to be aware, because this is we've kind of changed our face a little bit here with the Clinical Consultation Network. Previously, we were in a position where we were kind of pretty much focusing on more behavioral types of issues kind of exclusively. And we've kind of broadened that now to the point that we're looking at lots of different types of clinical issues. And so today is a prime example of that. This is something coming more from the medical realm. But it's important for everyone, regardless of what clinical discipline you work within, to learn more about what other disciplines do. Sometimes there is interdisciplinary work that has to be done. And so by learning from other disciplines, you can be a better recipient of their services. So just keep that in mind as we go through today. I also want to make everybody aware, speaking of interdisciplinary work, that on August 22nd, the Tennessee chapter of the National Association for Dual Diagnosis, also known as TNAD, will be having its annual conference. So I would like for everybody to go. I would like for you to go, but I would encourage you to go to the TNAD website and to learn more about the conference that's upcoming. We've got some great speakers. There's going to be a lot there about the use of technology for persons with intellectual and developmental disabilities and helping them to live more independent lives through the use of technology. So I encourage you to go to the TNAD website. That's at TN-NADD, N-A-D-D, TN-NADD.org, and you can learn all about the conference this year that's going to be occurring on August 22nd. I would also like to let people know about an event that's going on here at 3521 Esquire Drive this weekend. It's called the Horse Experience. And so this is an event where we invite people with disabilities. Notice I use the word disability rather than disability, because I generally think of people with disabilities as not being disabled but having a different ability. That was a term coined by Tim Shriver a few years ago, and I think it's a really great way of thinking about people with disabilities. But we've invited people with disabilities and people without disabilities to the Circle Heart Ranch for the horse experience. And so if you're interested in that, you can email me for more information. I'm bruce.davis@tn.gov, and we can get you connected with the horse experience. So we've got a lot of great things going on, and if there are announcements you'd like me to make at the beginning of the Clinical Consultation Network upcoming, please send those to me. I'd love to advertise whatever event you may have coming up. I was just thinking about this topic today, and I've been pondering it a lot because, as I've gotten a little bit older, I have gotten had sometimes some greater difficulties with my health, I guess I could say. It's not even long ago. I don't know if you recognize that guy. That's Jeff Bridges from The Big Lebowski, drinking a White Russian. He says, "Don't worry about getting older. You're still going to do dumb stuff, only slower." And I've certainly found that to be true. I'm doing things a lot slower these days, but it's a lot more painful. That's one of the things about growing old that I think makes it really difficult, is that you experience pain that you hadn't experienced, in quite some time, or that you'd never experienced before. And, especially I've been a relatively healthy person, but I started experiencing some of these things, and it does bring a lot more decisions into your life. You have to think a lot more about what you're going to do to try to address these different problems, and keeping different medications that you may take in balance. Lots of things to think about. I remember when I was a young person, my father had received a Christmas card from my uncle who lived in Oklahoma. They were about the same age, both advancing age, and my uncle had just written a little bit of a note on the card that my aunt had sent to my father and said, "I hope you're doing well, Ed. These golden years sure are the shits." Basically the way he reacted to, growing older and having a lot of those difficulties. So, I just think that is sort of an entree a little bit to the case we're going to be discussing today. I hope that that's not the case with this gentleman, but it does. The point being that we did have a lot more decisions that we face, a lot more treatment sometimes that we have to receive as we get a little bit older, and it becomes part of the furniture that we end up having to deal with. So I hope. So we'll is David Taylor. He's our director of nursing. David, you want to say hello to everybody out there?
Good afternoon, everybody, and welcome to today's CCN, and we're really glad to have Barb Burkitt from DS of Maryville here with us.
Hey, my name's Barb. It's breaking up. Can y'all hear me?
Yeah, Michelle,
okay.
I lost Dr. Davis's audio.
I lost my audio because I stepped on I pushed my mute button there. So I was speaking that entire time. So, Barb, I do want to introduce you. So Barb is the director of nursing at DNS in Maryville, Tennessee, and she is here today to talk to us about a case of a gentleman that I'll let her describe for you in a minute. But before we get into that, Barb, I'd like for you to tell us just a little bit about yourself and how you got into this job at DNS that you do.
Okay. Well, I have been a nurse since 1982. I started off as a respiratory therapist and went to nursing school. Most of my clinical career has been pediatric open heart, ICUs, ERs, trauma. Majority of it was ER and trauma. And I was teaching the med classes, PRN stuff, and learned about this system once I moved up here to Tennessee. And I had a special needs son who passed away 4 years ago that had a trach and oxygen. So I was familiar with the system, just not this aspect of it, the actual nursing, taking care of folks aspect other than my son. So then I, due to just difficulty schedule-wise in the hospital setting, accepted a job here at DNS in 2005, and I've been there, we were quite small then, and I've been their director of nursing since.
That's great. And so what do you like about your work there at DNS?
Well, clearly our folks, I like being a voice for them and assuring that they are our family, and so I like to assure that someone is their voice, and especially cases like this today and in some of our others, you know, because the one thing I have seen actually is quite upsetting to me is the way that even physicians view our folks as if they really don't have the choices, and they do. They have the same choice you and I have.
Right. Yeah, I think that's a very valid point, and I think a lot of physicians, you know, Dr. Cheatham, who was my predecessor in the position that I have, would often bring out the point that people who, you know, a lot of physicians out there have not really had a lot of exposure to people with intellectual disabilities. They, you know, in many ways treat them very much like a population that they're just not interested in, and that they're, you know, not going to give a fair shake to. So I'm very happy that you're out there doing those things on behalf of people. And so you've got an interesting case for us to discuss today.
I do.
I'll turn this over to you and let you kind of explain a little bit about him, but this is, you know, kind of going along with the theme that I have. This is a fellow who's getting a little bit older, who is in need of some treatment, and some decisions are having to be made and moving in that direction. So why don't you tell us a little bit more about the case?
Okay. Well, you use the name Danny. And he is a 70-year-old male, came to DNS in 2015 from a nursing home. And when we got him, we were told he had had a recent stroke and had had a hip fracture and a tib-fib fracture. So let me backtrack though a little bit. He was a motor vehicle crash at age 16. He was ejected from his car into a concrete wall. He had a very traumatic trach done at the scene by the ambulance drivers, and he ended up on a ventilator in ICU for 9 months. His mother took care of him for many, many years afterwards until she no longer could. And then his sister, he's got 6 sisters, and one of his sisters is an RN, worked at St. Mary's for many, many years, and I have grown to really have a great relationship with her. She's 87, but she is spunky. I love her. She's good people, and she cares very much for him. But anyway, she's not able to take care of him. I'm sorry.
To mention that must have been really interesting to kind of meet someone who previously worked in your profession and that you can communicate with in that way.
Yes, and it's interesting because all of our conversations, and I've sat many of hours at either her house talking about this and where we want to go and where she wants to go really with all this, and we always end up talking old nursing, so it's kind of nice.
Yeah.
It's really kind of nice. And she's, like I said, 87. And so she was back before me, but she's still, nursing is very different today than it was many, many years ago. So we kind of talk about that.
Yeah.
So, So anyway, he lived with his mama until she passed, and then he moved in with his sister, and her husband passed away of cancer, and so when she no longer could take care of him, he went to the Cerebral Palsy Center. He lived there for several years, and then back in 2015, which was right before we got him, is when he fell. Prior to that was ambulatory.
Let me ask a little bit of a clarifying question. So he went to the Cerebral Palsy Center, but did he have a diagnosis of cerebral palsy?
No, he was a traumatic brain injury.
Right. So that just happened to be a place that was providing care that would benefit him, but he was not the person who had a diagnosis of cerebral palsy prior to his accident. Okay.
Yeah. Oh. So he fell. He was ambulatory. He had a nasty fall, fractured his right hip and his right tib fib, and needed a lot of hardware put in. And during that process, now there's a discrepancy here. The sister says she was never told that he had a stroke, although he has very much stroke-like symptoms. He's got paralysis on one side, and at that time is when he initially started with swallowing difficulties as well. So I'm pretty sure was a stroke somewhere in that picture, but she says she was never officially told, but he could have thrown a clot or something during all this major surgery for his hips and all that.
So what was it from your experience that caused you to think that he had a stroke, that he had a stroke at some point?
His hemiplegia, where he has no use of that one arm.
Okay.
He also holds his head way to one side. He has not been ambulatory since that insult where he had the hip fracture and the repairs. And it doesn't sound like he really got a whole lot of PT in the nursing home. So that is one thing the sister and I talked about but she was going through her husband's cancer and death and all that. So I don't know that she was able to be on top of it during all this like she would have liked to. So there's clearly some sort of a cerebral insult that happened during that time, but we don't have a real clear picture of it.
Thanks for explaining that.
Okay. So then he came to us, and he came to us on a chopped diet. and pretty much ate normal. But in he had a great 2 years with us. But in April of 18, he was coughing a lot. We got, actually back in 16 he started coughing. We got a modified barium. At that time they changed him to ground and then shortly thereafter to a pureed diet. X-rays have never shown any aspiration, although his modified bariums show that he does aspirate. So dietary has been an issue. He did have a 10-pound weight loss or so at the beginning, which when they switched diets, which actually was okay. He needed to lose a little weight, but nothing significant. And then he's just plugged along until April of 18 was when pretty much a lot of our issues started. He was coughing a lot. A doctor ordered a modified barium swallow, and at that time he was aspirating nectar-thick barium. So they changed his diet to honey-thick pureed, and he's been doing great ever since as far as diet-wise, eating and not coughing and all that.
Barb, this
Yes.
is one of those little educational things, I think, for the group. So you mentioned nectar-thick versus honey-thick. And so can you explain that just a little bit?
Well, it's the consistency of the fluids that he drinks. And so one of them you should be able to have a spoon stand up in on its own. And the other one's a little bit thinner. But sometimes and if there's any SLP on the call, you might interject here. But are there any SLP on? No? Okay. Well, basically they watch a modified barium and see which one gets to the back of the throat and they don't cough and aspirate with it.
Oh, okay.
So they change those. Those get changed around a lot. And since we had a questionable stroke, I wasn't surprised that got changed around a little bit. Anyway, so the only other significant past history was in 2003, he also had thyroid cancer. And during that time, when they took his thyroid out, they actually went in and Dr. Nelson at UT did some fairly significant reconstructive surgery of his esophagus and airway there, mostly airway, from that old trach as well as the thyroid cancer. So he's got scar tissue there, which some paperwork shows that possibly that's why all the swallowing issues and there really wasn't a stroke. But I can't really decipher it, tell you the truth. It's kind of, I don't have all the records. But clearly it's a significant risk as well. So back in 18 is when we did the modified barium and switched his diet, and he's been doing fine diet-wise since. Gradually losing a little bit of weight. In August, he had of 18, he had a sudden onset of slurred speech one night with some facial droop. The staff called. We called 911. And by the time he got to the ER and did his CT, all of his symptoms had resolved. So they called it a TIA, which is a transit ischemia attack. But everyone it was documented that they did see the facial droop and the symptoms. So, go ahead.
So with a transient ischemia, it's as if you show some of the symptoms of stroke, but they're
intermittent.
Yeah.
Mm-hmm. They're intermittent. They come and go. Mm-hmm. And but it's a significant thing in that there's clearly some sort of blood flow issue, or they wouldn't be having these issues. So basically, it's sclerosis of the vessels.
So when you see someone who's had these types of events, you're still thinking that there's something in his circulatory system that is problematic.
Oh, yeah.
And so just because it comes and goes doesn't mean you're past it. You have to continue digging and trying to understand what it may be that's causing that.
Yeah, typically they do a workup that involves carotids to make sure there's no obstruction of the carotid arteries. They do ultrasounds. They typically put them on a aspirin regimen so that you don't throw little blood clots, and watch for seizures. So there's a lot of they check your cholesterol, all those kind of things. Which, by the way, his cholesterol is better than all of ours put together. So
that wasn't
no. So anyway, they did that reconstruction of the trach. So that was another risk of this swallowing issues with him. So he plugged along pretty good, but started losing weight, and it was fairly noticeable weight. Sent him to the doctor, asked them to review all of his meds and look at his thyroid, which was my first thought because of thyroid levels. Even though he'd had cancer and had it removed, you still have to watch levels. So we thought, well, maybe that's what's causing the weight loss, because it was pretty rapid. Everything was okay. So he continued losing weight. He was eating an enormous amount, but was losing weight. Then he started with 7, 8, 9 diarrhea stools a day. So we looked at GI, and they did a colonoscopy. It was essentially negative. But lo and behold, it was he was on a couple laxatives, and when he went to the pureed diet, evidently, which that was a learning lesson for me, was to watch laxative stuff when they're on, when you have a diet change. Even though I know that, it didn't click. And so they readjusted and took away a couple of his laxatives and stool softeners, and then his diarrhea went away. But he continued to lose weight, and all this started in...
let me break in, just ask a question about the pureed diet. I'm basically kind of just thinking about a pureed diet. And I think a lot of people, when they think about a pureed diet, they're thinking, oh, this is terrible. How did he react to having to be on a pureed diet?
That's interesting, because he does not like it at all.
Yeah.
And I'll talk about that a little bit later, if you don't mind.
Yeah, that's fine. That's fine.
Last appointment we went to. So anyway, so he continued to lose weight. So I called sister, we talked, and I said, well, what would you think about doing a cancer workup? I mean, he's got a history of cancer. She said, I think it's fabulous. So I called the doctor. We went to that appointment. Said, we really don't know what's going on. We can't find anything medically at this point. Can we start a cancer workup? Yes. That involved, labs, x-rays, CTs, blah, blah, blah. So the final, everything was negative. And they did cancer markers and all that, and everything was negative. So then it turned out he lost around 60 pounds. So the final workup.
This was a level of weight loss that was beyond what you might have expected from anything else, and you've ruled out by this point other possible causes of his weight loss.
Correct. We started with kind of the basics, looking at meds and seeing if we'd missed something, and kind of just started at the bottom and didn't want to put him through a whole lot, but because he is kind of fragile, but he's a trooper. He's the most positive person I think I've ever met in my life. He's constant smiles. But so anyway, in in this workup, everything was negative, and then in November of 18, they did the CT of the chest, abdomen, pelvis, and they did it with contrast, and it showed as they put it, huge hiatal hernia. And the report came back stating that his stomach was turned and not twisted totally, but turned and was up in his chest wall. So
can I ask, were there any, in his behavior, were there any significant changes in how he was responding or anything he was doing kind of to try to deal with this physical condition that he had?
No, and that's been the interesting thing. He still, as of last week, is why I feel great. Why are we doing all this? What's going on? You know, and we've explained everything.
Okay.
But he denies. Now, the one thing that he does have is his posture is very poor. He's wheelchair bound, and he does lean over and he's way to the right, and that's his normal posture. He will sit up straight on verbal cues, but he doesn't sit up totally straight. But his neck is very torsion to the right. Sister says she thinks that's just habit from years ago. But I think he's probably had a neck injury from this getting thrown into a concrete wall that wasn't a priority when he was half dead, you know?
Right.
So anyway, we did this CT, showed this huge hiatal hernia. His PCP actually called me and said, you know, he really needs to see a surgeon. I'm going to refer him over here to this cardiothoracic surgeon. And I said, that's fine, I'll get a hold of Sister. So I did. We sent him to the appointment. Sister went the first appointment, and she called me and said, well, they said they want to put a G-tube in. And I said, oh, G-tube, okay. She said, yeah, they explained they're going to pull this hernia, untwist it, pull it down, and put a G-tube in as an anchor. And I said, I said, well, the surgery is what's called a Nissan fundoplication, but I'm not sure about why a G-tube. She said, well, we're going back next week. Will you go? And I said, absolutely.
What made you question whether a G-tube was appropriate in this circumstance?
Well, because there's so many other ways to anchor down, and I didn't know where the G-tube part was coming from. That's not a normal thing unless you're having trouble swallowing. And I said, so do they think he's not going to be able to swallow? Was there issues with his higher in his esophagus, or did they think they couldn't get it anchored down to where he would be able to eat properly? And she said, I don't know all those. So I said, well, we'll go and talk. So we went, and plus Danny does not want a G-tube, and his sister did not want him to have one.
And this be a G-tube, so you were talking about his reaction to puree diet, but would this be a G-tube that he wouldn't be able to receive anything orally, or?
Well, there's two ways to look at that. You can either feed someone all of their nutrition through a G-tube and never eat, and those are the people that say have cancer or a medical reason where they could not use their esophagus. And then there's people that just don't eat enough or get enough nutritional support through through eating, that they have to get fed additionally through a G-tube. So I wanted to clarify if this meant, can he never eat again, or is this going to be? And so that was my questions going in.
And that really introduces that question of quality of life versus quantity of life, too, at that point. So that's important. And this question
opened a whole lot of floodgates. And so Danny does not want a tube. But if had to, he would. But he really wanted to be able to still eat. And so it would also change the dynamics of where he lives, because he doesn't have nursing in this house. and he absolutely loves where he lives and loves his housemates. So that was his big thing, more so than actually eating, was would he have to move? And, you know, I couldn't answer all of that totally because it's not cost effective to have a house that you just bring a nurse in at night either. So although I didn't discuss all that with him, I had to look at that whole picture too, you know. But anyway, so we went to the cardiothoracic surgeon's office. He was spent almost 2.5 hours with us. And his answer was he feels that this is a much needed surgery, that the stomach is twisted and up into the chest, and that he feels that, I said, what were the risks if we did nothing? And his answer was, well, that stomach could twist and you get no blood flow and then you end up in an emergency situation. And we said, which has about a 90% mortality rate. And we said, well, we don't want that. So decision was made after 2.5 hours to go ahead and do the surgery, but not do the G-tube unless they absolutely had to. And he explained that when I get in there, I may see a total different picture, and we may not have to do it. But if we have to, are you okay with it? And both Danny and his sister said yes. So they wanted to wait and not do anything because this was all right before Thanksgiving. They did not want to do anything till after the first of the year because they were having a bunch of family get together. And the doctor said that that would be acceptable, but any belly pain to go directly to the ER. So,
and he's not complaining of any symptoms
nothing,
at this point.
Nothing.
Yeah.
And he asked him numerous times about that. So we went back January and met with Dr. Budd again, and he felt very certain that we needed to do the surgery and do it soon. So the surgery was set up for the 16th of January, and Betty looked up Betty's the sister, I'm sorry. She looked up the doctor and researched him, and she was quite comfortable. And so we get to the hospital at 6 a.m. the morning of the surgery, and when we got there, and then in between that there was a anesthesia appointment, and I made sure they were aware that he had, and the one was recent, the TIAs, because he had two, one in August and one in November. So I wanted to make sure they knew that and had all that information. So when we got there the morning of the surgery, the nurse put us in a room and said, don't get changed into a gown yet because anesthesia wants to talk to you. And we said, okay. And I said to Betty, well, I guarantee you this is about the recent TIA. And she goes, yeah, probably is. Well, then in walks the anesthesiologist, and this is where it starts getting interesting. She basically said, why are you doing the surgery? And Betty said, because the thoracic surgeon said it's needed. And that his stomach was turned and blah, blah, blah. And she says, well, I don't know that that's what I'm seeing. She said, and I had GI come consult and read these CTs, and I'm not so sure, would you talk to them? And Betty said, well, yeah. And so they came in, 2 or 3 of them came in. All of a sudden the surgeon comes in, and in 40-some years of nursing, I have never experienced anything like this in my life. In comes the surgeon. It's this big powwow that everybody clearly disagreed on whether or not this needed to be done. Poor Danny is just going, I just want to eat. And so after 5 hours and 20 minutes, the decision was made that because there was so much disagreement, Betty was frankly lost confidence. And she wanted me to make a decision, and I said, I cannot do that. If you're really unclear and really scared now, You know, maybe this is a sign. I don't know. But she said, I'm not doing it. And if we do, we're going somewhere else. So in comes the surgeon again, and all these hospital people apologizing, and it was very inappropriate. It was very inappropriate. Their fighting and carrying on right there was not appropriate at all.
Yeah, and so I'm wondering. First of all, it seems unusual that an anesthesiologist would be making that kind of judgment on things.
Well,
now, straighten me out on that if I'm wrong about it.
Well, you know, initially I thought, what is going on? And the more I thought about it and watched everybody, I actually felt, I walked out of there thinking, she's not comfortable putting him to sleep. And then I thought about it and I went, you know what? She's the one that's going to get sued when something goes wrong. And I thought, you know, I kind of gave her credit, and Betty and I went in the hall. She asked me to come talk in the hall, and I said, can we look at it from this perspective? I said, I'm kind of grateful she spoke up. If she really spoke up, if she really felt that this was right, I don't think she'd have spoke up.
But her concern, as you're bringing it out now, was more about whether he was going to be able to tolerate the anesthesia, perhaps, than it was about his condition. She was adding that rationale to her hesitation because of his history of transient ischemia.
Right.
Well, David, this is Rhonda. Anesthesiologists are all about risk. They do one after another, after another, after another. They don't look at anything else except what is going to keep this patient alive on the table. Because, and she's right, if anybody's going to be sued over a death on the table, it'll be the anesthesiologist. Because they're the ones that has to monitor the patient for how they're doing during the surgery.
Right.
And even if they do everything right, the finger still gets pointed at them.
Right.
Well, let me just say that's very. The interesting part about that is for others of us to understand the dynamic that exists there, and with that, and how that might affect different members of the team's judgment as to what needs to happen in a given situation. So that's really good stuff.
So the way it was handled was probably not very appropriate, and there were many apologies even from the hospital administrator about that. And it was very clear that the surgeon and the anesthesiologist were not BFFs, you know? And so that to me raised a red flag, because you got to have a good working relationship, especially in something like this.
Right.
So I kind of walked away with a different feel than the rest of them. Because I thought, you know, I wouldn't want somebody doing this major surgery on me if there was going to be all this interpersonal conflict, you know?
Right.
So, and I thought, well, maybe she sees or senses something that doesn't feel right. And she kept saying, I'm not seeing where his stomach is twisted and up in the chest. We asked to look at the CTs, and of course nobody could find them. And I thought, well, they got to be in your OR. I said, they got to be in your OR. You're fixing to cut on them, you know? Anyway, bottom line, we walked out 5.5 hours later, hungry and no surgery. So Betty calls me and says, will you call the PCP and talk to him? I said, I will. So I called him, and he, of course, went on and on apologizing, said he got numerous calls, and that I said, listen, no apologies needed. I just want what's best for him, as does his family. And he said, I said, but I am going to tell you, I'm not certain the family has the confidence they had prior to this. So I'm thinking that if there is any surgery comes out of this, they told me they want to go to UT. He said, I'll work with you however. So I asked him, I said, why did we not get GI involved initially? And he said, because I felt it was critical and needed to go straight to the surgeon. And I said, okay, that's fine. So I said, well, I think Sister would like to have GI see him. She said, fine. He said, fine. So we went to GI on, I got a minute. We went to GI. Oh, in the meantime, we got a second CT as a follow-up, and it showed even worse. It showed that, yes, the stomach is up in the chest, as is the colon now, part of the colon. So now we're looking at a more emergent thing where you can get what's called a volvulus, where the colon twists,
Yeah.
and when that happens, you pretty much die right then.
Yeah. So his condition was worsening, and you at this point I'm still wondering if he was having any symptoms yet.
No symptoms. To this day, has 0 symptoms. So.
Hey, Bob, doesn't that create a real dilemma in how you take care of him?
Yeah, absolutely. That's where I'm losing a lot of sleep here. So now we're sitting on a even worsening CT, and the CT doesn't lie, you know. So I asked if what if he had a volvulus and they called me, say, in the middle of the night and said, he's got severe belly pain. And I know this doctor, and he said, what would you do? He said, and I said, well, I'd send him to the ER. And I said, but my question is, what would you guys do? I said, we're in an emergency situation now. And he said, exactly. And we would do the minimum, which would be pull the, untwist and pull everything down and figure it all out later if he needed more surgery. But, so in the meantime, we go to Dr. Young for GI. He says, oh, he's got to go immediately to Greg Mancini, the surgeon. We go to Dr. Mancini on 423, and I happen to know all those because I worked at UT, so it was a very frank conversation, and it was actually very good. But his first thing was what happened over there, and I told him, and he said, I'm okay with that. And I said, well, I'm okay with the decisions that were made, but it was a weird situation. He says, yeah, that was not very professional. He said, but let me ask you, Danny. He starts talking to Danny, and he said, let me ask you. He said, do you have any trouble eating? He said, no. He said, what would you like to eat? He said, I want a hamburger, French fries, apple pie, and a milkshake from McDonald's. And Danny, he says, you know, you're 70 years old. Most life expectancy is for a male is 70, 71. He said, have you lived a good life? He says, I have. Yeah, I love it. I love my folks at my house. I'm happy. He said, so really all you want to do is eat a hamburger. This was another weird thing. A hamburger, French fries, apple pie. He said, I'll write an order right now for that. And I said, Greg, don't do that. I said, don't do that yet. That would get SLP and all of us in a lot of trouble. Hang on. He said, listen, he turns to Betty. He says, what is your expectation if I did surgery today? What is it you want for Danny? And she kind of sat there, and she says, I want Danny to be able to eat what he wants. And he said, do you think this surgery is going to change that? And she said, well, I don't know. I'm asking you. And he said, well, it may improve some, yes. But I don't know that he won't choke. I don't know that. And so then I said, what if I had to do CPR on him? And everything's up in his chest. And So these are my questions. So the bottom line is, Dr. Mancini said, if anesthesia doesn't clear him here, and there's a chance they won't because you've already got one
especially
anesthesiologist.
with, the previous history of that.
He said that's a setup for if something happens, somebody's going to say in a court of law, I told them it wasn't safe. So he said first thing before I'll do anything is anesthesia has to clear him. And then he said he would have to have probably a pulmonary workup. So Betty was okay with that.
Let me ask this question. He said he wanted a hamburger and a shake and apple pie and all those really good foods. But given the condition that he has, it seems to me it would have been difficult for him to be able to process that. I mean, for that to work for him. So how is he able to digest his food, and be able to eat normally if he has that condition that he has?
Well, that's the $1 million question is that Dr. Mancini even said, if we did the first part of this procedure, which would be a Nissan fundoplication, which is where they take the end of the esophagus and the stomach and move things around and kind of line everything back up so they have a straight shot down the esophagus into the stomach. Right now, everything gets caught up at that end of the esophagus.
Okay. So
he said, the simple thing would be to go in and untwist what they could, fix what they could, and no G tube, and call it a day, and let him eat what he wants. And, of course, that's all Danny heard and his sister, But Dr. Mancini's views also are, what do you want as far as quality of life?
Right.
And, of course, that started another hour-long conversation. So Danny's family would like for him to be a DNR. Danny wants everything done. Well, to do this major surgery and be a DNR, chances are nobody will do it. Because there's such a risk that they want to be able to, on the table, if something happens, they don't want to say, well, the family don't want anything done, because in court they're going to say, well, then why were you doing all this?
Right.
So I did a post with the sister last week and the doctor, and I went to the appointment and talked to Dr. TCT. So
we're running a little bit short on time, but Barb, I want to ask you quickly to explain. You used the word DNR, which I think everyone knows, do not resuscitate. But you also used the term post, which is remind me what the acronym is.
So, physician's order, I don't know, David, what is?
Physician's order scope of treatment. You remind me what it is.
Scope of treatment. So basically the post, a DNR says don't do anything. Do not resuscitate, don't do nothing. A post gives you several options. You could say take a G-tube for some period of time and see if you get better. You could have antibiotics or fluids for some period of time in hopes that you get better, and then say after 2 weeks if you're no better, then stop everything. So a post is just a little more involved and gives you a few more options, I guess is how I would put it.
And this could be suspended during surgery also.
And most hospitals want everybody to now be, and I just had this too, they wanted us to reverse a DNR for just the procedure.
I'm glad you brought that up. That's a topic that we could get into, and probably as you guys were having a brisk discussion about this, would really create a lot more discussion around the DNR. I will say we're getting a little bit close on time. Just want to ask you to kind of help us understand where we are, what's next in Danny's case.
So we left the surgeon's office with family, all the sisters and Danny talking about what they really, a real frank discussion about what you really want. If what you want is not to be resuscitated and just eat what you want, that can be done. That's your choice. Or do you want the surgery and the kind of basic surgery to fix and hope that maybe it extends your life and your quality of life? And so then we went to anesthesia, and they have not officially cleared yet. They did EKG and labs, and they want some other testing before they'll agree to even do the surgery. So the bottom line is, I guess where I'm kind of sitting is, what if they do not do any surgery, and he is a full code, and he gets a volvulus? What do? I'm going to send him to the ER, and I hate that for him. I hate for him to have to go through.
And what if he chokes eating?
Pardon? Yes, I know.
Yeah, what if he chokes?
Well, he hasn't had any trouble on his pureed diet, but if he were to eat a hamburger or something, I don't know. You know, I've asked the doctor to please not write regular diet yet till all these other decisions are made, and he agreed. So,
well, what a fact!
Y'all are still just waiting, huh?
We're waiting, and I'm not and I'm getting nervous about we're working on close to 9 months that that if something, and he said he could have a volvulus tomorrow, Barb, and die, or he could not have a volvulus and live another 4 years and die of a big fat heart attack. We don't know that. And I said, I agree.
Well, this is a fascinating case. David and Barb, I'm so glad that we had this case to discuss today. And Barb, I really want to applaud the effort that you have put into understanding his situation and working with the family in particular to help, her, the sister understand everything that's going on and working with her closely, making sure he gets the type of health care that he needs. He is, obviously this is an enigma because his demeanor does not suggest a person who's physiologically in distress, it sounds like, but
it does not, and that's what everybody's perplexed about, is he says there is nothing, he feels fine, he does everything he can to be independent. I don't know. I've never seen anything like it, but I'm glad he's happy.
I see where it's difficult to conduct the benefit risk analysis in this circumstance because the other side of it is, well, we've got these CT scans that we've done that show a really bad picture here of something that portends a very, very bad situation for him. So it's certainly a dilemma, and I think is going to be the subject of ongoing benefit risk analysis as you go forward. And, it would make it so much easier if he were expressing any kind of pain or discomfort under this circumstance, or was being limited.
It's kind of like end of life with cancer. Quit doing all these tests and finding more information to make your decisions harder,
Yeah, I can see that.
Go with what you got and make a decision, and I don't know.
Yeah, well, sometimes you have to do that. There is something called a circumstance where your goal is to make a decision as simple as possible, but not simpler. And unfortunately, a lot of these circumstances are very complex, and it really takes someone like you following the case and putting two and two together, helping the doctors understand everything that's gone on before, the history of the situation, and where it all came from to be able to be successful. And I really want to thank you for coming on today and explaining that to us. I'll just pause quickly. Michelle, are there any questions that we need to respond to at this point?
There's none in the chat.
Okay. Anybody want to come on and ask a quick question? We've got to wrap up here pretty quickly.
Hey, Michelle, is it Barbara? This is
Yes.
Edie. I'm an occupational therapist. You say he does receive speech-language pathology, and I'm sure the pathologist has tried, because quality of life for him is so important. And, of course, you can certainly puree a hamburger and an apple pie.
Yeah.
And then has all the techniques been tried of giving small amounts at a time, with assistance. All of that's been tried, I'm sure.
His thing is he wants to hold a hamburger and an apple pie and eat it out puree.
Yeah, he doesn't want to puree.
Yeah. And, his sister even said to me, Barb, if we weren't having to follow, and this is no offense to anybody, but it is the truth, if we weren't having to have and follow all the guidelines of the system he is in, how would you handle it? Her asking me, and I said, I hope I'm not coming across like I'm only worried about the nursing or, making sure I don't end up in a death review over all this, but also wanted to, my goal regardless is what is his wishes.
Right.
And whatever his wishes are, we will do a informed consent. And if he wants a hamburger tomorrow, we'll do an informed consent, I guess.
Yeah. It's always the place that you have to start, I think, with any decision making. Yes, there are rules and we have to, try to abide by them. But, it's not going to help you. The thing that will happen if you start becoming too focused on rules and not enough on what's important for the person is that it'll affect your judgment at some point. And you'll begin to rule things out that maybe you don't need to rule out in a given situation. And but I'm not saying don't follow the rules, but I'm saying that's the context that you have to understand them in. And so I think that is of critical importance. Thank you so much, Barb, for coming today.
No problem. Thank you.
And David for arranging this. This has been the Clinical Consultation Network. We do this every week on Tuesdays at 1:30 p.m. Central. And so I hope you'll join us again next week where we've got a fascinating case about a person with autism spectrum disorder who is facing some similar types of scenarios that we're talking about, but it's complicated also by some different behavioral issues that she has. So this will be a very good interdisciplinary case that we'll discuss next week. Hope to see you here. Clinical Consultation Network. Thank you so much. Bye-bye.
Thank you.